We've got to look at some specific areas of analysis with the lumbar spine, particularly in terms of instability testing, because we don't want to be manipulating people that are unstable. And if we are going to be manipulating people that have got some degree of hypermobility, we need to be able to recognize it and protect it within the levers. And so it is important that we just analyze that, and few people do in terms of groups out there, I don't think. And yet instability seems to be one of the buzzwords right now, doesn't it, of the courses that are being done. I know Stan Paris is doing a day course now all over the place on instability and all this kind of stuff. So this is the new thing on the block, the new kid on the block at the moment. So what comes up in 2 years' time, when everybody's done courses on instability, I don't know. The Norwegians have been doing it for a long, long time and running very good courses for probably the last 15 years. But their particular healthcare system can address the problems of instability better than ours, because patients can go for longer periods of time, and many of them have got health spas or health clubs attached to the clinics. So patients go from patients to being participants in the health club, which they pay for, okay, as a natural just progression from this to this group. And so many of these patients are under, or not treatment, but under supervision, from the treatment to the supervised exercise to the non-supervised exercise, for anything up to a year. Now that doesn't fit into our $300 business. I mean, you could go through that in 3 weeks if you did a patient sort of like 5 times a week or something. You know, so this is a tough business as to how do we tackle this in terms of the cost and the healthcare unit, and, you know, what's out there in terms of what's being recognized by paying agencies. And we've got to sort of address this, because certainly when you look at any degree of osteoarthrosis, there's going to be some time within that phase where hypermobility is the dysfunctional state, until the joint starts to become osteophytic and start to tighten up. And so this is a big thing, and I think we've got to address it properly. I placed an article in your notes from a Finnish study showing some of the consequences of excessive movement in the segment damaging the dorsal ramus. And if it damages the dorsal ramus, it's going to damage the muscles which are supplied by that medial branch of the dorsal ramus. And we're looking at all these intrinsic muscles that we spend a lot of time trying to re-educate. So we need to address this, no question. So we need to recognize it on manipulation courses so that we don't excessively stress the unstable segments, that we protect them within the levers, and that we don't get caught up, like very often we've been done in the past, at manipulating some of these joints, because unquestionably many of them feel better for a while. I don't know why this is, but they kind of get stuck at a sort of perhaps an extreme of movement, and you move it and it's okay, but we're not addressing the problem, we're just addressing the symptoms that keep occurring. So after we've perhaps moved one of these things, then we've got to go into looking at stabilizing it. And I'm not suggesting that we manipulate these, but I know in the past that I've done this, and I think everybody else has done it. And these are the patients that you do well with, and then they come in and you do well again because they were very impressed with you, and the next time they come in it's a bit shorter and you've got to see them a bit longer, and then they start driving you crazy because you're not doing, well, you got me better so well, why is it taking so long now? You know, and these are very often, we've got to be looking back at these patients and trying to recognize this instability. So that's got to be part of what we do. So then we'll do the techniques for the lumbar spine, and then I'd like to, today at least, get into and considering the cervicothoracic junction, so that we can kind of spread it around, because then we've got the sacroiliacs to do, and I don't want to be doing the sacroiliacs immediately on top of doing the lumbar spine. We've got to give ourselves rests. Now, how about the soreness at the moment? Do we have anybody that's particularly sore? Surprising, isn't it? All that sort of clanking, and you know, you've been very good as models. I've been quite impressed. Have another go at that. Have another go. Oh, on the other side. You know, and you've all been doing this and cooperating very well, and yet here we are, 4th day, still smiling, not kind of walking like this. And that's very good, considering most of us have all got neck problems or spinal problems. I mean, physical therapists are a hotbed of dysfunction. And that's very good. Excellent. Now, let's just go over some of these things. How many degrees of freedom are we looking at in these lumbar segments? Tell me.
3.
Better get reading at your Punjabi and white. 6. Because we've got 3 angular movements and the translations that go along with those angular movements. Now, what's the relationship to the translation and the angular movement in relationship to instability? What's your feelings about that? Think about that for a second, and before you answer it, tell me the classical L4-5, which we usually sort of take as our average vertebra, and indeed there's a lot of problems occur at 4-5, so it's probably a good one to take. Better than what Nakamson did when he took 3 and looked at all the pressure changes at the one where there's very little trouble. Okay, and I mean, maybe technically much more difficult to do elsewhere, but these are the changes within the disc that are constantly being brought forwards, and it was at a disc that, on the whole, doesn't give very much problem. So we're looking at our average one in terms of the instantaneous center of rotation, or axis of rotation. So this is 4 here, and this is 5 here. Where would we place that? How about your group, Dave? The moratorium on asking you questions has stopped. Now you're a day older. Where is the instantaneous center of rotation? 4-5. Where would you place it?
Vertebral bodies.
Whereabouts in the vertebral bodies?
Posterior third.
Of a body or?
Disc.
Of the disc. So we'd put it in the posterior annulus somewhere like that. All right, would be the instantaneous center of rotation for the X and the Y and the Z axis. All right, now then, what's the relationship to this and instability? Can you go on with that? And tie it in with the translations that go on.
Well, what I know is that if the facet's impact, the axis will change. The axis will actually center around whichever facet is impacted, and good chance of getting breakdown there, and then hypermobility on the opposite side.
Okay. Anybody else like to address that one? You heard what Dave said, that it makes a difference as we start to get, he's sort of taken it a stage 2 or 3 beyond what I wanted just at the moment. Anybody else would like to address the problems of translation and angular movement? And tell me what's in my head. Yes, yeah, all I want to know is, what is your feelings thinking about instability and the relationship between translation movements and angular movements, both of which are a concomitant of any movement that we do to give us this 6 degrees of freedom? Now I've rephrased it, Barb, you're going to answer it because it's so clear.
Well, I think it depends on what state of instability you're talking about, but I think there's generally an increase in translation.
Yes.
As far as angular movements, there can be more, there can be less.
Mm-hmm.
And it depends on the state of the articular cartilage, it depends on how much of the disc has degenerated.
Mm-hmm. So we're dealing with, we're dealing with the breakdown of a segment, aren't we? The total segment, and I think we've got to really consider this. It's like in the cervical spine, we're dealing with a 5-joint segment there. Here we're dealing with a 3-joint segment, and we tend to sort of say, like with muscle energy, you know, it's always sort of described because it's convenient that there's a block in this facet, therefore this thing moves like this. We can never say that. All we can say is that the segment is behaving as if there is a block in here, but it could be any of the other restraint factors that are causing a problem. So when we look at this and we talk about angular movement here, and we're moving into that direction, then we get a translation in the same direction as the angular movement. And this is what is hysteresis or creep. Now then, if we start to get a breakdown in the segment, or just let me backtrack a minute, and if we were to look on the top of this disc like this, and here we've got the instantaneous center of rotation, because we've got a creep occurring with an angular movement, we kind of have an envelope here of motion, don't we, over which this instantaneous center might move. But it's contained within a fairly restricted envelope. But once there's a breakdown starts to occur in all of the structures, and of course probably it's in the collagen structures to start with, and then it's going to be picked up by the body attempting to stabilize it a little bit with the other restraint factors. But that envelope is going to get a bit bigger, and the movement becomes a little erratic within the envelope. And I think a very good way of looking at instability, in my opinion, is to kind of look at something like an anterior cruciate tear, where you can go into a position and suddenly you start getting shifts, such as the Macintosh pivot shift, when you go into a position and then we get an unusual and an uncontrolled shift across the glide. And that's very difficult for the body to control because it knows nothing about this. It's not a movement we learn to control. It's an abnormal set of circumstances, and particularly if we start getting a breakdown in the neurology of the joint too, the body doesn't know how to tackle this. So when we're talking about the degrees of freedom and what we are doing now, I think it's the relationship between the angular movement and the translation that we're looking at, and that when we get into a breakdown, we can get more of a shift in the translation, which means that the angular movement isn't going to be controlled, because we could get all sorts of abnormal shifts. You could now start getting a sort of a backward movement with the angular movement when it should go forward. And so these, I mean, obviously contained, but these are still things that we have to handle. And when you come to testing these things, a lot of the things that we test is the translation movement, isn't it? We do posterior anterior shears to look at this particular translation. So that's really quite an important sort of consideration for us. Now, if we took any of the pictures of, and I'll have to kind of pull this up and down. If we looked at any of these pictures, this is taken from Dvorak's book, and you'll see that if we take flexion, lateral bending to one side, axial rotation and the other, there are differences in the measurements come up by the workers, which might represent how the tests were done and how the measurements were done, but on the whole there's sort of correlationship with 1 or 2 degrees out in any particular range. I'd like to just address the axial rotation because there's very little change in this kind of analysis. And in vitro by Yamamoto here of 2.1 rotation, Piercy is much more into a mean of about 1 degree in terms of rotation. Why I'm mentioning rotation is that rotation with flexion is very often the way that the back is kind of seriously and significantly damaged. And we should try and address that in terms of how the absorption takes place. If we look at the motions of flexion plus extension, we'll see there are some differences here, and the differences are certainly reflected over the whole of the segment, so that we're coming down from 10 to 17 degrees at S1. And we really should consider this because this looks like a huge range of flexion and extension here. Hayes 14 degrees, Piercy 14 degrees, back to Dvorak 17 degrees. So we've got a difference of opinion. But the interesting thing is that when you look at some of the work that's come from Bogduk and Tomey, it shows that the spine never ever gets flexed that the maximum that ever happens is that the lordotic curve is reduced, and that L5-S1 never ever gets into a flexed position. It's always somewhat extended. So when you look at that 17 degrees, it's going back from extension to less extension, and that's a lot of movement, it seems to me, to be represented from what they're saying, which is always retaining the lumbosacral angle and flattening. And their suggestion with flexion is that the only bones that actually flex, where the front part of the disc actually now starts to compress with a little bit of anterior shear, is when we start to get up to L1 and T12. All of the rest of them go from the extended lordotic position to a kind of a straight position. So it's always interesting to me to look at these big ranges of motion and then look at the work of people like Bogduk and Tomy and try and sort of put that stuff together. One of the pictures that's a little bit more helpful perhaps than that is one of the ones that's been brought by Greg Grieve, where he did a number of years ago, and this will be a bit old now, a number of years ago, looking at the sort of average ranges of motion of the lumbar spine here. This is the whole spine, but just the lumbar spine here. And we can see the flexion and extension seems to increase as we get lower down, and that would fit in with all of the workers. We sort of learned originally with Kaltenborn to test extension for L5-S1 and test flexion for L4-5. You know, and have a look, and if that was reversed in terms of the flexion at L5-S1 was greater than L4-5, we should be thinking in terms of hypermobility. And that was a thing a number of years ago that we sort of spoke of. If we look at rotation, we'll see that doesn't alter very much in any part of the spine, but that side flexion has a kind of a bell curve with the maximum at L3-4, very little at 5-S1, and about 2 degrees or so, or 2.5 degrees of rotation in most parts of the lumbar spine, with the exception of the T12-L1 area here, where it's a little greater. So these are sort of things for us to remember, that there's very restricted lumbar rotation, and the restraint factors for this are obviously fairly efficient. And this is what I'm going to sort of not present exactly, but to talk about in terms of the work done by the chiropractors, Cassidy, who sort of talks about the side posture, not the side flexion, but the side posture manipulation. Perhaps we should rethink it and its whole consequences for how much care do we have to take? We have to take care, but do we automatically discount it if we think that there's some discal derangement? He feels we shouldn't, and he's working in the Saskatchewan Hospital Orthopedic Department Research Division, and they've looked at this in terms of CAT scans, and nobody was made worse. Now, you can review this, not his work, because that's a recent article, but you can review the work of Kirkcaldy Willis on this, who worked with Cassidy, of course, because Kirkcaldy Willis was the head of the department. And in the first part of your book, in the manipulation theory, I've given you a chapter by Kirkcaldy Willis, which goes over some of the work that they did with all kinds of problems like spinal stenosis and things that we wouldn't really think about manipulating, and very few of them were made worse. Some of them it didn't help, but very few were made worse, and I think that's a feeling that we can have with the lumbar spine, with our protocol and working out the instabilities, that we should be able to sort of proceed carefully but with confidence in the lumbar spine. All right, let's just go on a little bit now and just try and finish some of these things off. This diagram, I think, is an important one, taken from Bogduk and Tomy. Okay, if I stick this on and it's miles up and I'm talking to you and I've kind of not noticed this, you'd think it would be a fundamental that somebody puts something on and they check out that it's on the screen. But sometimes you don't for some reason. Okay, let's have a look at the picture on Fig 7.1 there on the right-hand side of the board. This is coming into extension. Now, remember in extension, we used to sort of think about close pack and so on, but what it's been found now is that as we come back into extension, and you know this from your previous courses, the bones here, the facets here descend onto the lamina, make a contact with the lamina, there is a continuing movement back here, and the upper part of the facet will gap open. So this is kind of when we think of close pack and all this kind of stuff, you know, this is not an absolute thing. You'd think, okay, here's maximum approximation, but then we get into this situation where it starts to sort of spring backwards. Now, this might be a consequence. We need to get into extension, of course, but if we're constantly doing this in the presence of perhaps a joint down here that cannot go into extension, the consequences is that we're going to create a hypermobility at this level coming back. And I think with Robin Mackenzie's stuff, not to address the intersegmental motion, perhaps not in every patient, but certainly in those that are having kind of recalcitrant back problems, perhaps we should be doing passive mobilization and not just have an active programmed. Because if we keep pushing back, and this one here is very stiff, the only thing that can happen here is that we can start getting impaction here with bruising, and this sort of coming back. But extension and lordosis is very important, because when we come into this diagram, one of the ways that we resist compression is by taking not just the compression through the disc, which of course with the nucleus, but also the resistance of the annulus, which is very, very strong in resisting compression. But this comes back onto this facet onto the lamina and shares out the load. So we've got a bony impaction here, which is quite normal, and the whole of this segment withstands compression through this mechanism and that mechanism. In one of the articles that I've given you within the body of Book 2, we have the section on acute back pain, acute neck pain, and thoracic pain by Bogduck. So we've got a similar writer all the time, and might have disadvantages that because you get his biases, but I think actually he's very, very sensible in those articles. And one of the things that he talks about in terms of acute back pain that has been achieved by going into extension is a periostitis created and an articular bruising that's created as these joints have gone suddenly back and bore this weight here and caused quite a lot of significant damage here, as it would if we fell on any other joint. So we get all of the chemical reactions within the joint that result from bruising of the cartilage, the lysosomes and all of these things that create a synovitis as well as a periostitis. And we should try and link that in with some of Farfan's stress tests, which we'll do a little later on. Now, when we come into flexion, this is the point about flexion, that we never really reverse the flexion. As you see here, there is somewhat of a reversal, but they're sort of saying that these are not the whole level, of course, these are individual levels, and this would show up probably a little bit more at the higher levels where there's a little bit more of what we would consider to be a flexion of a segment. And as you see, we get the translation which is resisted by the impaction here of the upper part of the facet joint in flexion. And if you remember, the facet joints are particularly able to stand this forward shear because they're all J-shaped. And so that front J will stand this impaction of the forward translating vertebral body. Of course, we can see that if we look at this particular picture, in flexion on the whole, the facet joints are opening up. If we look back at that other one here, the facet joints are essentially going back into their smallest diameter position. The other thing that we should think about is when we go into instability, while we're talking about this particular diagram here, is that one of the features of instability on an X-ray is retrolesthesis, where this has settled down closer, and in effect the superior facet of the inferior vertebra has moved upwards and forwards into the intervertebral space. That is a sort of characteristic, isn't it, of retrolesthesis. So these are things that we should take into consideration. Here's a picture from Diane Lee's book. She has some excellent kind of diagrams. She's got a very good artist that works with her. But this is a concept that Bogduck has also come up with, that can we talk about the X and the Y and the Z axes, particularly the Y and the Z axis, in terms of the way that the spine moves. If we have an instantaneous motion of coupling, of a side flexion and rotation, is it possible to kind of consider that the rotational axis is this and the side flexion axis is that, if both of them take place simultaneously? And so he postulates, and Diane has got the diagram here, of this oblique axis. And that is how it takes place, with instantaneous coupling. So the X and the Y axis, or the Y and the Z axis, looking at the way it moves, would seem to be a kind of an artifact of description. And in fact, it's an oblique axis which exists over which these bones move. And of course, when we're testing motion, we've got to kind of try and visualize in our minds, to some extent, that oblique axis. And we tend to try and do it over the pure Cartesian axes, which probably are not absolutely as it should be. When we come to L5-S1, let's say there is some problems with L5 and S1 in terms of the way that this is understood to move. Of course, the function of this joint is different from the others. The body has developed this adaptation to withstand strong anterior shears by having the facets coronal instead of only having that front little edge resisting it. We've also got the development of what? The iliolumbar ligaments, particularly the posterior fibers that go from the ilia to the transverse process. If we look at the transverse process of L5, it is distinctly different to any of the other transverse processes. They come from the pedicles. You look at the transverse process of L5, and it is a massive structure which comes from the side of the body. Just have a look at this in terms, you can see it there on this plastic copy here. Massive as compared with the much finer transverse processes arising from the pedicles. And that's because of the absorption of these rotary and translation stresses. It's buttressed to stand all this through the iliolumbar ligament. Now, of course, all those ligaments and the change of the facets, and also knowing that the facets are often irregular, has produced different things here. And I don't know, you know, Gratowiecki talks about it rotating opposite. Piercy talks about it rotating in the same direction, whatever position it's in. Fortunately, when we try and move it, we'll be doing a rotation across a vertical axis.